Okay, now that I've figured out how to work my computer, I uploaded the new Explorer. It made a little bit of difference. Alright, well, let's get this slideshow going. Let's talk about some brown fat. I have all kinds of fat, but I don't think I have any brown fat. Brown fat usually starts to appear during the 17 to 20 weeks of gestation during a time of development. It's usually located in below the nape of the neck where the little folds are noted in the interscapular region, under the arms and the axillas, and posterior to the sternum. And it's a very important for these babies to have the brown fat, especially if they get cold stressed, because it's usually not even used unless they get stressed and not able to keep their temperature up, and then they start burning their brown fat. Brown fat burns a lot quicker. So thermoregulation is what we're looking at in babies. We want them to become thermoregulated. We want them to be able to, within that first 6 to 8 hours, to be able to regulate their temperatures. Usually, though, it takes somewhere up to 12 hours for them to be able, for the amount of heat loss that they're having to equal the amount of heat that they can produce. So usually they're losing more heat than they can produce if we don't intervene and make sure they're in a thermoregulated environment, making sure that their area is warm, and make sure that we keep them dressed warm, we keep a hat on them, especially in that first 24 or in that first 12 hours. Um, there are some anatomical and physiological characteristics of the newborn that put them at risk for heat loss. They have less adipose tissue. They don't have a lot of fatty tissue between their skin and the rest of and their muscles. They just don't have it there. Even though that we think they're little fat cheeks and they're little fat, they're not really. They really don't have enough adipose tissue. They have less subcutaneous fat, and their blood vessels are really close to the skin, so that as the blood flows through, the environmental temperature can affect that. Um, and then they do have that large surface to body weight. I mean, babies' heads and chests are extremely large according to their body weight. So they are actually have these characteristics that put them at risk for body weight. So a lot of times babies, when they want to try to conserve their heat, will assume that position of flexion, the what we call the fetal position. They will flex in. Their body will assume that position of flexion. And the reason it does that, it diminishes the body surface exposure that's exposed to air. So the closer they can draw in their extremities to their body, the less of their body and extremities are exposed to air. They're just next to each other. Um, a lot of times they will also constrict peripheral blood vessels. The neonate will be able to do that. So what happens with that, when they constrict those peripheral blood vessels in order to conserve heat for the major body portion, is that you're going to see the hands and the feet be blue, what we call acrocyanosis. And that's not, that doesn't mean that they're having an oxygen problem. It means that they're having a problem staying warm. And you might want to be, watch that. But acrocyanosis is usually normal in the newborn. And we're going to talk about that a little bit later on when we're talking about newborn physical features. Okay, thermogenesis, which is, of course, the creation of the heat. Usually, babies will increase their muscle activity. They signs and symptoms of cold stress that you're going to see in a baby are going to be restlessness and crying. The increased cellular activity causes the fat to burn up, causes glucose to be burned, which they use up their glucose. So if they're cold stressed, they're going to use up their glucose, and then they're going to become hypoglycemic. And they're also going to use up oxygen trying to burn the glucose to try to stay warm. So you are seeing a compromise in their glucose. They'll become hypoglycemic. You will see a compromise in their oxygen. They will become hypoxic. So cold stress can lead to the babies actually going into cardiac respiratory distress or arrest, either or. They are not able to shiver. They can't produce heat. The newborn's primary method for heat production is when they metabolize the brown fat. So the brown fat is very important. When you have a preterm infant, they have a much less supply of brown fat because it only starts developing at that 17 to 20 weeks. So you really want to, that's why the preterm infant has so much trouble with regulation of the heat. They don't have that stores of brown fat to fall back on. So it's very unique to newborns. It will usually disappear not long after they're born. It can increase their heat productivity as much as 100%. That's a lot. And of course, the reserves, because there's only those few spots, remember, that we named, the interscapular region, the axillary areas, and the posterior to the sternum. That's not a whole lot of area for brown fat. And you think about the size of the infant and how small, or the neonate, and how small the sternum is and how small their axillary are. There's not really a whole lot of that brown fat there. So it can be rapidly depleted. And again, the less mature that infant is, the lower the reserves they have. All right, let's talk about heat loss. Convection, radiation, evaporation, and conduction. Convection is when you lose heat from the flow of the heat from the body surface to cooler ambient air. Radiation is where you get loss of heat from body surface to cooler solid surface that's not in direct contact but is close by. It radiates to it. Evaporation, of course, is the loss of heat that occurs when liquid is turned into a vapor. It's called insensible water loss, so to speak. Conduction is when you have loss of heat from body surface to cooler surface that are in direct contact. So basically what you're going to see is when you have flow of heat, when you have convection, it's when the environment is a lot cooler than it should be and the body surfaces are exposed. So say the baby's lying there in his stopper, just born, and you don't have anything to warm him with, and you've got him in this cooler air, then he can actually lose heat through convection. If you've laid him in a cold, if you put him in a warmer that you didn't turn on, but you put him in warm blankets, even if you put him on warm blankets, the cooler sides of that warmer will pull heat from the baby. That's being radiated from it. If you don't dry them off when they're wet, the evaporation of that liquid off of the baby is going to cause them to cool off. It's like when you sweat and it evaporates, you're a lot cooler. So that's going to cause them to have loss of heat that way. And then conduction is usually always occurs when you take the baby and you lay them on the scales to weigh them. Scales are never warmed. The scales are cold. You lay a warm baby on a cold scale. The warmth from the baby is going to conduct into that cold scale. So that's how that works. Be able to recognize it. Conduction, convection, and these pictures were much clearer when I had them. They may be clearer in a smaller screen. Evaporation, when the baby's wet and you're seeing insensible water loss. And then radiation, where the heat from the baby is like going toward this window. The baby's lying there and there's cold area there. And then convection is where air is blowing over the baby. Like mom's hot, she's got a fan on her. That happens a lot. And then conduction is when he's laid right on a cold surface. Be able to recognize it. Cold stress. Usually when the baby's exposed to the cold, they cry, they get restless, they start having moving around, stretching to try to generate some heat. It's the only way they can usually generate heat is by trying to increase their metabolism by crying, moving around. Then, of course, they develop, they start having more metabolic and physiological demands, and that's going to increase because they're trying to warm themselves up. And as these things increase, we have increase in respiration, we have an increase in oxygen consumption, and then the oxygen consumption and energy is diverted from maintaining the brain and cardiac function to maintaining thermogenesis. So all of this cold stress can actually cause you to have a whole lot of just tumbling events that occur. When the infant's temperature is less than 97 axillary, we want to bring that temperature up, but we want to bring it up slowly. You don't want to just stick the baby in and just warm him up quickly. If you bring up the temperature too quickly, you can cause respiratory arrest due to that negative feedback, the body mechanism that we have. If we warm him up too quickly, then the metabolic system may start shutting down because it's been raised, and then we will see respiratory arrest occur because the body thinks they don't need to have all that respiration going on. And so you may see respiratory arrest occurring if we warm them up too quickly. So you want to make sure that we warm them, but we don't warm them too quickly. The best thing to do is to prevent it. And I found this little flow sheet that I thought was a really a good little chart here. Evaporation, conduction, convection, radiation, decreased body temperature, and cold stress. And then it shows you what all happens. You have the metabolism of your brown fat that we talked about, increased metabolic rate. Then you start having that vasoconstriction where your hands and feet turn blue, the peripheral vessels. Then you start seeing the pulmonary vessels starting to constrict. Now, that's a bad thing. Then over here in the metabolic rate, we talked about using up the glucose, using up the oxygen. When we use the glucose, turns into hypoglycemia. When we use the oxygen, the decrease of the production of surfactant goes down, and then we have hypoxemia, which both of these will result in respiratory distress. And then, of course, these over here, vasoconstriction, you can see that it will lead to respiratory distress. Metabolism of our brown fat is going to increase production of acids, and we'll see metabolic acidosis occurring. Displacement of bilirubin, now that's a bad thing. Now, we didn't talk about this portion right here, and I don't really expect you to know this portion right here. I don't think that it's really mentioned in your book, but this portion here and this portion here and all these portions up here are all something that we just talked about and you need to know about. On the flip side of that is hyperthermia. Hyperthermia is when their body temperature is greater than 99.5 axillary, and you have an overheated infant. Neonates do not normally run hyperthermia. I mean, they don't have temperatures related to infections normally because they don't have that immune response. They have a very immature immune response, and they are not able to generate a fever to fight infection. So usually when you're seeing hyperthermia, it's usually because we have overwrapped the baby. And you'll see this a lot in Hispanic babies when you talk about cultural preferences. You can go into a Hispanic baby's room and the baby's lying in the crib and you can barely see the baby for all the blankets that he has wrapped around him. He will have on a undershirt, he will have on a gown or a sleeper, he will have two or three small infant blankets, and then he will have those big fluffy blankets all wrapped up around the baby. Barely can breathe. And it's really a risk for SIDS to occur when you have a baby's temperature high and have them wrapped up so much. It actually can impede their respirations. So this is a big opportunity for teaching. Um, if we do see the temperature, if none of that, if they're not overwrapped, they're not in too warm of a temperature, and we're still having hyperthermia, then we need to look at sepsis as being the cause for that. They usually look stressed, they're pale, and we'll see some cerebral damage if we don't get this temperature down. I did actually have a baby that had a temperature of 100 and 3 axillary, and even unwrapped 30 minutes later it was 103 axillary, and turned out mom had strep D, and the baby had to go to Children's to get treated for that. So you want to be very cautious about taking the temperature, making sure you are taking your temperature appropriately. Most babies' temperatures are taken axillary, although we do teach rectal temperatures. Moms are not encouraged to do rectal temperatures because of possible perforation of the anus. Usually, babies have 6 times more sweat glands, but they don't work. So if they don't work, they're not going to help the baby get rid of hyperthermia. And again, hypothermia and hyperthermia develop rapidly due to that large surface area. They can actually have dehydration, heat stroke, and death from all this. Remember what we said the heart rate would be? I'm waiting. Oh, I can't hear you. That's right. I wish I could. Maybe one of these days we'll have to figure out to do a Skype or something. Of course, it'd be hard to do each one of y'all individually. So the heart rate, remember we talked about at first period of reactivity, the heart rate increases, and after that period of reactivity, it decreases. Normally, it will start, the heart rate should normally settle down and be consistent at about 140. Now, in postpartum babies, you may see a heart rate of 110. Again, your assessment of your infant or your neonate should be according, don't just go call the doctor at 110 and say, oh my God, this baby's got bradycardia, without saying, okay, the pulse ox is running at 98%, the color's fine, respirations are so and so, and blah, blah, blah. And the baby, maybe the baby was in a deep sleep when you got it at 110 and 120. Maybe you need to stimulate the baby a little bit. But it's not uncommon for post-term babies to run a little bit lower. So, usually it ranges. Even during deep sleep, they may be as low as 70 to 90. And it can range from 120 to 150 when they're awake. You're going to find their PMI. Actually, the infants is usually, I changed that and I meant to change it on my PowerPoint, but this was one thing that escaped me. I changed that. Infant is usually 85 to 100 during deep sleep, and usually 120 to 160 beats per minute while awake. So please note that change, that instead of 70 to 90, it's 85 to 100 and 120 to 160. That was one thing that did fail to go in and change. I did change a lot of other things, but I failed to do this one. Your PMI is found at that fourth intercostal space, left to the midclavicular line. You will usually be hearing sinus arrhythmia. It's usually not it's not going to be a steady, continuous beat, and it's a good indication of good heart function. Heart increases and decreases as the baby moves because they have a very low cardiac output, and the circulatory system works on increased heart rate and being able to maintain cardiac output. If we have any heart murmurs from the ductus not closing or the foraminal valley staying open, they usually totally disappear by 6 months. They are followed. It's not like we say, oh, here's your baby, take it home, it has a murmur. If we hear a murmur, we have to document we hear a murmur. We have to be sure that we document it. We call the doctor, and the doctor follows up with that. They usually do an echo or whatever to make sure that it's not anything more serious than the ductus and things not closing. You know, it could be a ventricular septal defect. So they want to check those things to make sure what the heart murmurs from. So if it's not disappeared by 6 months, they do interventions. The foraminal valley would be treated much like an atrial septal defect would be, and they would actually take care of that. If sometimes sinus arrhythmia, if it's real irregular heartbeats are being heard and it continues during a wake cycle, you might want to look for other signs of what might possibly be causing those to happen. Of course, with our fetal circulation, we're going to be coming back to that again. Our venous ductus and arterial ductus are usually closed by 3 to 4 weeks after birth. Remember that the ductus connects the aorta to the pulmonary artery to bypass the lung in the fetal circulation, and that foraminal valley connects the right and left atrium. It will close right after birth because of the pressure gradients. If it fails to close, you will hear a murmur. It should be closed permanently within 4 months of birth. And if those things don't happen, then we'll have to do surgical intervention. When you are taking an infant's pulse, you should always do an apical pulse, and you should always do it for at least 1 minute. If you don't, you cannot get the rhythm. You cannot detect irregular heartbeats. And so you want to be sure that you are doing those things. All right. Your average values of blood pressure are 60 to 80 millimeters of mercury systolically and 40 to 50 diastolic. This does not mean there cannot be some variations. We do not normally see blood pressures being done in a neonate. They're not routine vital signs. Usually, if a baby's in distress, it'll be admitted to the nursery, and then blood pressures will be done in all 4 extremities. It's been noted that some hospitals will do blood pressures when the baby is born. They may just take a blood pressure in one area. But if you're going to do a blood pressure on a neonate, you really should do all 4 extremities, because really the comparison of the upper extremities to the lower extremities can tell you a lot of information about the baby. So it should be done that way. Their blood volume, they should have around 85 mils per kilogram. So, our renal system, you want to be sure, again, like I told you, be sure to note whether they have a voiding or not. Usually if we feel any masses around in the renal area, it's in the abdomen, it usually is related to the kidneys. They do have, again, that limited ability to concentrate the urine, which makes them at a high risk for dehydration. and they cannot manage large increases in fluid volume. So we really have to be careful about calculating fluid volume um, for these infants if they're on IV. So that's very important because they can get fluid overload very, very quickly. Um, Sometimes you will see infants having a pink tinge on their diaper. Females, it can be related to a maternal hormone influence and is like a pseudo menstrual cycle. You have to be sure and teach the parents that this is normal because they'll freak out. Or it can be due to uric acid crystals, and this is usually from maybe a small amount of urine and a large amount of uric acid crystals in the urine because of the decreased fluid that's able to flush through the kidneys. And you can see that on male or female infants, and that's not abnormal to see in the first 24 hours or so. Um, if you have your little male patient gets a circumcision, you want to be sure that you're monitoring them for spotting. Make sure that if they are, you teach the parents to watch for bleeding right after the circumcision. You should monitor for bleeding, apply pressure if they are having bleeding. Again, the gastrointestinal system is not mature at birth. Remember, the vitamin K is not synthesized in the gut. That's why we give the vitamin K. We can see Epstein pearls, which are little false teeth. Babies really have to work at learning how to suck, swallow, digest, metabolize, absorb, um, because their body has to learn to absorb proteins, carbs, and fats. They've never had to digest them before. It's all been just served into their blood vessels, and they just, don't have to worry about it. Um, you want to be sure to monitor for look for the Epstein pearls, and of course assess the hard and soft palate. And it's not abnormal to see Epstein pearls. It is abnormal to see actual teeth, but the Epstein pearls, you can tell the difference between the Epstein pearls actually look like little pearls sitting along the gum line, whereas the teeth actually look like a little tooth in there. Their sucking is usually in bursts. They don't just suck, 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 suck. They'll suck like 3 or 4 times and then they'll rest. And then they'll suck 3 or 4 times and then they'll rest. They are not able to move food from their lips to their pharynx, and that doesn't develop until they're about 6 months old. So you do not want to try to feed a neonate any other method other than giving them a bottle or breast or a syringe or something where you can move the food back to their pharynx so they can swallow it. A lot of times you will see new parents trying to give a baby a bottle and just insert the nipple portion into the mouth instead of the entire nipple with the flange at the back. You have to place it well in the baby's mouth. This is where a lot of breastfeeding falls down, and then a lot of the tissue has to go into the baby's mouth. So um, things that you want to look for to make sure that they are sucking correctly. They have full cheeks, and in those little cheeks are their sucking pads, and that's one of their special mechanisms that help allow them to suck, swallow, and breathe. So they need to suck, swallow, and breathe. And some babies don't have that reflex down. Sometimes they'll suck, 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 swallow, swallow, suck, swallow, and forget to breathe. And you'll have to take the food away from them, the bottle or the nipple away from them, and encourage them to breathe, and then put them back on the bottle or the breast. Remember, with our gastrointestinal system, that our meconium is sterile as well as our urine. So our urine and our meconium is sterile at birth. There is should not be any type of bacteria or anything in it because the guts have not been working. So everything that's in there should be sterile. Your capacity of the stomach is usually about 30 meals. sometimes it can go up to 90 mils. But if you'll think about 30 mils, that's about the size of a silly putty container or a little small banny egg. It's very small. And some babies are even smaller than that. That's why breastfeeding, even if it's not large amounts, can satisfy babies because their stomachs are just not very large. Emptying time is going to vary. Some of them empty quickly, some of them it takes them a while for their digestive system to kick in and start working. Their stool, of course, is the meconium. It's a greenish black tarry viscous. It also has occult blood in it if there's been any bleeding at all in the intestinal area. That first passage is sterile, but the rest is not. Because after that first stool, the rest of the stool that comes through has been contaminated by the gut starting to work and food being in there. If they don't have any stool in that 48 to 72 hours, there may be an obstruction in there. If they have a mucus plug, they may have cystic fibrosis. It should be changing colors in 2 to 3 days. Be sure you note when it's changing to transitional stool. Instead of being tarry and dark green, it'll be kind of a limeish green. And it will look in a different consistency. It will be kind be a lot thinner. And eventually, with formula fed babies, it will formed stools, usually brown or yellow. Breastfed babies will always be a pasty type of stool. They will not usually have formed stools like they will with a formula fed baby. What you feed them is going to affect their emptying time. Breastfed babies empty quickly because the food is highly digestible. Temperature of the food. If you want your baby to gain weight, if you have worrying about that and you're feeding them room temperature formula, you should go to feeding them warm formula. It will digest faster. Um, Sometimes psychological stress, the baby's stressed out and crying a lot, can affect the baby's emptying time. You want to teach the parents to avoid regurgitation by allowing them to eat too much. You want them to feed the baby about 10 cc's and then burp. 10 cc's and then burp. They should feed them at a position where the head is slightly elevated. My favorite position is to set them on the knee and hold their head up. But of course, parents like to hold them in that cuddle hold, so they need to have them with their head slightly elevated. Their hepatic system is where we're going to see the iron storage that parents are concerned about. Conjugation of bilirubin is going to occur there. There is some availability of iron in breast milk is far superior to iron fortified formula, but that's only their iron stores in a term infant. Um, they're born with iron stores in their liver, and a term infant has enough to last 4 to 6 months. So they don't really get concerned about breast milk not having added iron because of that 4 to 6 month store. Now, if you have a mother who was sadly anemic, that store may not be there, and your baby may be born with a low hematocrit and hemoglobin. And you will know that when you look at the lab, and if you see a low hemoglobin and hematocrit, you know that they probably a result that of mom having a low hematocrit and hemoglobin. So you always want to correlate that, because if that's not the case, then there's something else going on with your baby you need to be notifying your doctor of. Um, you usually don't want to give any supplementation until after 6 months of iron for a breastfed baby. Um, our glucose levels, we'll talk about those, but of course they are related to our GI system. Glucose levels usually should be between 45 and 80. Anything below 45 is usually needed to be treated. So you want to be sure and check your glucose. Preterm infants, if it's less than 35. All these need interventions. They should be fed immediately if their glucose is low. And we'll talk more about that in a minute. Okay, laboratory. Y'all that have gone to the nursery at White County have looked at baby CBCs. And we've talked about white blood cell count. A blood cell count of 18,000 is normal, and I'd much rather see a white blood cell count of 27,000 as to see one that's 7,000. A low white blood cell count is a big serious sign of sepsis, especially if you're seeing a decline in those neutrophils. Serious infections are not tolerated well at all with in newborns. Their cells are large, and the reason that they have a large amount of cells, they have a high hematocrit, is because they need it to carry the oxygen sufficiently. So usually you're going to see a hemoglobin being between 14 and 24, and a hematocrit will be in between 44 and 64. If it's higher than 64, you're looking at polycythemia, where they have too many red blood cells. Usually you will, if you see a hematocrit that's over 65%, it could be due to delayed cord cutting. The baby was lower, and the gravitational flow of the blood caused the hematocrit to go up, or it could be that mom has maternal diabetes. Mom may have hypertension. So those are some things that you want to look at if you have a large hematocrit. If they have a polycythemia, you're going to have to watch very closely for jaundice, because you're going to have the breakdown of all those immature blood cells, and the liver is too immature to take care of the billy that's being broken down, and so that's where you see the billy is related into the subcutaneous tissue, which is causing the yellow color in the infant. So when you do a lab draw, the source of where you get it's very important. Usually, capillary blood cells yield a higher level than the venous blood cell. So those are things that we want to be sure that we're taking a very close look at in our lab. So which of the following labs would indicate severe sepsis? Hematocrit of 48? Nope, that's normal, isn't it? Yep. Platelets, 250,000 platelets. I did not go over, but platelet count is, their count is right in line with an adult. Their platelet count should be about the same as an adult for norms. 27,000 white blood cell count. Well, that would not indicate severe sepsis, because the infant does not have a good immune system, and they don't produce the white blood cells to fight the infection. The white blood cells that they have get used up while they're fighting that infection, and that's why we end up with a WBC of a 7,000, and that is severe sepsis. So that is the explanation of that question. Okay. All right. So this is why we didn't talk about platelets. Here we go. 150 to 350,000. If the baby's mom takes aspirin or Thorazine, it could range lower or higher, depending on the effect of it. Those levels, we've already talked about them not being able to synthesize vitamin K, and it's due to the decrease factor 2, 7, 9, and 10. And they can't synthesize it, and so administration of that vitamin K is going to help enhance clotting and help prevent bleeding. It takes several hours for the vitamin K to kick in, so you can't just give it and expect it to work within the next 20 minutes. A lot of people think if you give the vitamin K and then you do a blood draw 5 minutes later, that the reason that it's hard to do the blood draw and that it clots is because of the vitamin K, and that's not so. You never ever want to give vitamin K IV to an infant. You always want to give it IM, and the dosage is 1 milligram, or yeah, 1 milligram, half a meal. So you want to be sure that you're very careful about giving vitamin K, making sure it's the correct dosage. Blood glucose levels should be approximately 50, 40 to 50, 40 to 60 milligrams deciliter. Your book has 50, so we went with 50. So 50 to 60 is where it should approximately be. You want to be assessing your infant. If you have any jitteriness or tremors, you definitely want to check a glucose level to rule out hypoglycemia, especially right at birth, because their glucose supply has been cut off and they still have insulin production going for that supply of glucose. So you really want to watch what type of fluids that mom has going. If she has D5 going in her fluids, chances are your baby's had a high insulin production because he had high glucose. And when that fluid's cut off, you're going to start seeing all the insulin's going to do away with what glucose is there, and then there's not going to be any. So you really want to watch that, especially diabetic mothers. Um, you want to be sure and to check out babies who are large for gestational age or premature babies. There's certain babies that are at risk for that. Glucose, of course, is that main source of energy during that first 4 to 6 hours of life. And sometimes, used to, they wouldn't feed a baby. They wouldn't feed a baby when it's first born. They'd make them NPO for 6 hours. Of course, we don't have that practice now. And we don't have the practice of feeding them water to test to see if they have a patent esophagus. We don't do all that anymore. In fact, we highly discourage water at all in the first 6 months of life to babies. They get enough fluid through their formula or their breast milk. And you want them to eat the calories to be able to maintain their metabolic needs. And we didn't talk about, when we talked about the GI system and the hepatic, which this is still part of the hepatic system, is the bilirubin. The bilirubin, of course, is yellow pigment that is a result of the breakdown of the hemoglobin and myoglobin in the body system. We can have physiological jaundice or neonatal hyperbilirubinemia. Is normal. It normally occurs in about 50% of your full term and 80% of your preterm infants. Physiological jaundice usually is a result of underfeeding, breastfeeding, whereas pathological jaundice is due to a disease process that may be existing, such as ABO incompatibility. So if your mom has O positive blood or O negative blood, and your baby is A or B, and your baby's starting to turn, you need to monitor your baby carefully for ABO incompatibility, which will show up as pathological jaundice. And it's much more dangerous than the physiological jaundice. Unconjugated bilirubin, indirect bili, is insoluble, and it binds to albumin, which causes it to go into the vascular systems and causes, and that's the unconjugated bili. Conjugated bili is excreted from liver cells, and we do a direct bili for that. It is water soluble, and it excretes through urine and stool. Total bili, which is what we normally do, is both the indirect and direct. The indirect usually has a smaller value than the direct bili. So we just do a total bili on neonates. It's called neonatal bilirubin. But it's a total bili, and it should never be more than 12. So, physiological jaundice. Our criteria for physiological jaundice. Our infant's well. There's nothing wrong with our baby. Appears after 24 hours. And it's usually gone by the 7th day. If we have a baby that's jaundiced before 24 hours, we need to be calling the doctor. There is probably a pathological underlying disease process going on. In premature infants, you usually don't see jaundice being evident until after 48 hours, and it takes it a little longer for it to disappear. What helps it disappear is frequent feedings. If we have a baby that's not well and not able to feed, then we have to give fluids. But we're talking about a well infant. So we need to feed frequently. Usually these babies are not eating well if it's physiological jaundice and we're not able to flush it out of the kidneys. The conjugated bilirubin cannot be excreted out if we don't have anything to excrete it out with. And it's really wicked to see the stool from a baby who's starting to pull out bilirubin. It looks like sesame seeds from the top of a sesame seed bun inside the belly, and it smells to high heaven. You can walk in the room and say, I smell a bilirubin stool when you're being a good nursery nurse. Serum concentration of unconjugated bilirubin should not exceed 12 in a term or 15 in a preterm. So we definitely want to be sure that we are not seeing those processing out. At any serum bilirubin level, the appearance of jaundice, again, like I said before, should not appear in that 24-hour period. If it does, we should be calling the doctor. I've put in this little, and this is in your book as well. It didn't used to be in your book, but it is now. This is a really excellent tool to use to determine if the bilirubin level needs to be treated. It actually takes in the hour, how old the baby is in hours to the bilirubin, and tells you whether you should treat or not treat, or how you should treat. Should you treat with just increased feed? Should you treat with phototherapy? Y'all should go and look at that. It's a fairly neat site. We now have transcutaneous monitoring that most nurseries have now, where they can just run this little scanner over the skin, and it will tell you pretty accurately what a bilirubin is. You can't actually determine how high a baby's bilirubin is by looking at it to see how yellow it is, but it does occur in a cephalocaudal manner, in that the face will turn yellow, and then the chest will turn yellow, and then of course goes on down to the rest of the body. And the farther down it goes, usually the higher the bilirubin is. I did have a doctor who at one point in time could actually look at it and tell you what the baby's bilirubin is, but the most, of course, accurate is the serum billy. So if you have a transcutaneous monitoring that you've done and it's over 12 milligrams, then per deciliter you need to do a serum billy. Jaundice, of course, I just told you that, didn't I? Feeding within that first few hours usually keeps bilirubin levels low, because it stimulates our intestinal activity and we pass out stool. The more stool and urine we pass out, the more bilirubin we pass out, so it doesn't get to conjugate into the skin. Phototherapy, be sure your baby's unclothed. And when we say unclothed, that usually means without clothing, but leave the diaper on. If you don't leave the diaper on, you got a big mess on your hand. So, be sure that you are leaving the diaper on. And usually your phototherapy light if you're using a standard phototherapy light, it's 15 to 20 centimeters from the light. Now we have newer phototherapy lights that are built into our incubators, and so there's a standard height that they use. We should turn our baby every 2 hours to expose all body surface and prevent burning of the skin. Don't ever put oil or lotion on the baby while they're under belly therapy. They could burn. Be sure that their eyes are covered during the whole time that they're under the lights, and be sure we're monitoring their temperature every 2 hours when we go in and turn them. If they're inside an incubator, it could get too warm, and if they're out in an open crib, they could get too cold. So we want to monitor the temperatures and such. If we are obtaining a bilirubin specimen, we want to turn the light off to collect our specimen and take our specimen away from the light before we turn the light back on. The baby should have periods of time that the mask and the lights removed so he can have some actual bonding time with his mom, and so we can assess the eyes and such. Be sure that after we terminate our therapy that we retest for the bilirubin to make sure that we're not having a rebound in the bilirubin. Is very important. And all bilirubin is collected in a brown tube to protect it from the light. So if you're ever doing a bilirubin collection and someone collects it in a clear tube, it will affect the bilirubin level because light will destroy the bilirubin. And along with the bilirubin, kernicterus is a serious complication of hyperbilirubinemia. It's very severe. It can result in CP, epilepsy, mental retardation. A lot of times the infant just doesn't survive at all. It's usually when the bilirubin levels are greater than 25 millimeters of mercury. Babies are lethargic, hypotonic. They don't have a good suck. If we don't treat them, we can see them becoming hypertonic, where they have a backward arching of their neck and their trunk. Their cry is really high pitched. They will even develop a fever. It's been very rare that we've seen this, but there has been an increase in it in the recent years because we do have shorter stays in the hospital, which causes babies to go home with an increase of neonatal jaundice. So it is a large concern. Now they are recommending that a baseline bilirubin be done on all infants, even the low-risk infants, so that they can be retested if they start showing signs of jaundice before they go home from the hospital. Okay, breastfeeding term infant is 24 hours old, beginning to look jaundice. His bilirubin level is 9.7. What should we do? What did we say? It had to be above 12 before we think it's high, so 9.7 is getting close to the high side, but we wouldn't put him under the belly light. Never ever supplement a breastfeeding baby with formula unless it's just like a last resort. Don't put babies in the window in the sunlight, although we still have doctors recommending that because a lot of babies get sunburnt. We don't recommend that anymore. But we want to encourage the mom to increase the amount of breastfeeding she does and increase the time and frequency of the feeding at the breast. This will help her milk come in better and give the baby more food to be able to pass out the bilirubin through stool and urine. All right, coagulation factors. This is still dealing with our hepatic system. Coagulation factors are activated, of course, by vitamin K, like we said. And then the lack of the intestinal bacteria is what results in the deficiency between the second and fifth day of life. So we give them that injection of vitamin K to prevent clotting matters. I'm going to stop this one here.